Hello, I'm Dr. Elizabeth Stone. Now, I know that sounds formal, and when I take my students to clinical, I ask them to call me Elizabeth. So I want you to think of this video series as you and I being in clinical together. I'll guide you through the most important growth and development concepts, just like I do with my own nursing students. We're going to do this together. So today, I'm Elizabeth to you, and you're in my pediatric clinical group, which is, by the way, one of my favorite parts of being a nursing faculty. Now that we're talking about names, I'm going to use a picture of an adorable baby throughout this presentation, and Lecturio asked me to name her. Since I get to choose, we're going to call her Jenna, because that's my daughter's name. Throughout this series, we'll watch Jenna go through developmental milestones from infancy through her teen years. I'll share real-life examples from my daughter's life, and sometimes even compare her brother's experience to hers. So if you're a parent already, you can also use your child's experience to compare what I will be showing you as the normal experience. All kids are different, but it's important that you know how the majority of children develop to identify those kids who are struggling a little bit, kind of like Jenna. Are you ready? Let's get started. We're going to go through some important infant development milestones. We're going to go through weight, reflexes, motor milestones, and cognitive milestones in this growth and development series. Let's start with weight. When Jenna was born, she was over 9 pounds, and that's because she came from a healthy mother. She was born at normal gestation, so at full term, and because she was a healthy child. She had healthy genetics as well. So all of these things contribute to the birth weight. However, after birth, it's normal for every baby to lose a little bit of body weight, up to 5 to 10% in the first 10 days. But by about 2 weeks of age, they should have regained that weight and be back at least to their birth weight. They should be getting more alert. And their body weight should be rising quickly, as long as they're eating well. By 4 to 6 months of age, they should have doubled their birth weight. So that's a good rule of thumb to remember. After about the first year, their weight gain slows down, which makes sense because they're getting more active. So they're burning more calories. They gain about 2.2 kilos or 5 pounds through age 1 and 2. So that wraps up the weight. Let's move on to reflexes. Think about reflexes like survival mechanisms, and that's the same case whether you're an adult or an infant. In adulthood, actually throughout life, we have a cough reflex and a gag reflex, both of which prevent us from choking and can save our life. There are other reflexes that are appearing at birth, and then they fade away eventually throughout that first year. And we're going to go over the major ones. Let's start with the stepping reflex. This is a reflex that occurs, actually, in a way, it helps a child learn to find the mother's breast. It occurs if their feet are put against a flat surface, including if they're put on the mother's abdomen and they feel the abdomen. They start actually stepping and kind of crawling in a rudimentary way towards the breast, towards their food source. This disappears around 2 months. And then the rooting reflex is another one that's really common, especially as we try to teach infants to feed or to find the breast. If the cheek is stroked by a finger or by a nipple, they often will go towards that sensation. And a lot of times it helps them latch on to a nipple from a bottle or from a breast. This disappears around 4 months. The palmar grasp is something that a lot of people get pretty excited about, especially grandparents, as they reach out to try to hold their little newborn grandchild's finger, and the child will actually grasp it. It's actually a reflex, but you don't have to tell them that. Anything that you put in their palm when they're a young baby, they will try to grasp. This goes away around 5 to 6 months as their movements become more intentional, and then they're grabbing things that they really want. The Moro reflex is the next one, and this is kind of a funny one. They look like they're scared. So this occurs in response to a sound or a stimulus that is a touch from somebody else, or it could be even a movement that they make or that somebody else makes and they don't expect. They'll suddenly flail their arms back and put their head back, and sometimes they'll cry. And basically, it's like a startle. So Moro and startle are kind of interchanged. Those are both terms that are used for this. This reflex disappears around 2 months. And the tonic neck reflex, this is another one that has a couple different names. You may hear it called the fencing position or the fencing reflex. And this is a reflex that occurs sometimes if the child's head is turned to one side, their arm will go to that same side and stretch out, and the opposite arm will flex as if they're shooting a bow and arrow. We don't really know what that reflex really does for them, but it's kind of funny, and it's something that is checked at newborn assessments and at infant assessments as part of their neurological assessment. The plantar grasp is the last one we'll review now, and that is a lot like the palmar grasp reflex, but it's with their foot. So if their foot is stroked, the bottom of it, the plantar surface, it'll also try to grasp whatever that object is that's stroking it. And that disappears towards the age of 1 year.
Now let's talk about some key differences between the pediatric and the adult respiratory system. We're going to talk through each of these major differences. Let's start with the chest and thoracic shape. In infants and young children, the ribs are attached horizontally to the vertebra and to the sternum, while an older child or adult has a more oblique angle. Here you can see that the trachea bifurcates or divides at the level of T3 in children, while in adults, the trachea bifurcates lower at a level of T6. Now, the right main stem bronchus in children has a steeper slope than in adults, and this is important in the setting of intubation. The shape of the chest wall is also going to mature gradually from a relatively round shape in utero to a more flattened shape in adulthood. Here you can see at 3 months, at 3.5 years, and then finally in adulthood with full expansion. The shape of the chest can be due to genetic factors or due to external forces that are going to promote chest deformities. Scoliosis, which is a sideways curvature of the spine, can make it difficult for the lungs to operate at full capacity. The curvature can cause an asymmetric ventilation and perfusion between the right and left lungs in more than half of children with scoliosis. Kyphosis is a spinal disorder in which an excessive outward curve of the spine results in an abnormal rounding of the upper back. It can occur at any age, but this is commonly seen in adolescents. The altered shape of the spine can affect the heart and the lungs' ability to function properly. Now, this is a picture of a patient with pectus excavatum, and this is a condition in a child's chest that causes it to look sunken or caved in. And this happens because of a defect in the cartilage that's going to hold the bony parts of the ribs to the sternum. The cartilage is actually going to push the sternum inward. This can be mild, moderate, or severe, and the sternum can actually intrude on the space that's dedicated for the heart and lungs, causing shortness of breath and other respiratory compromise. This can be corrected surgically. Here's a patient with the opposite deformity called pectus carinatum. In this case, the chest wall is going to jut out into a convex shape. This happens because of unusual growth of the rib and sternal cartilage. This condition usually does not impair the cardiac and respiratory function because it's not really infringing on any chest wall space. Now let's talk about the diaphragm and the muscles of respiration. The diaphragm is the primary muscle used for inspiration in pediatric patients because the other surrounding muscles are also immature and mostly inactive. The angle of insertion in infants is more horizontal than in older children and adults. The young child's diaphragm has a lower content of high-endurance muscle fibers, putting at a higher risk of fatigue. If the function of the diaphragm is impaired, the ventilation is going to be compromised. Now, air moves in and out of the lungs due to changes in pressure gradients created by the movement of the chest wall and the use of the chest wall muscles. Inspiration is an active process. It requires energy. During inspiration, the diaphragm, intercostal muscles, and accessory muscles are used to bring the air into the body. When you expire or breathe out, this is a passive action. It can involve active use of abdominal muscles, for example, during a cough. In infancy, the intercostal muscles are inactive and poorly developed, so they aren't much help in the setting of respiratory distress. The abdominal muscles are going to mature and help stabilize the rib cage around 3 to 4 months of age. But again, before that age, these muscles are of little help, and that's why young babies can do really poorly in the setting of respiratory compromise. Now let's talk about the pediatric relative internal organ size. Here you see the bones and the bony structures overlaying the organs in the chest cavity. Pediatric internal organs are relatively large in relation to the infant or child size, and this can be a real problem. The increased size of the organs in proximity to the lungs leaves little space for increased chest expansion. With these limited opportunities for chest expansion due to their anatomy, a young pediatric patient can only attempt to increase their lung function by increasing their respiratory rate, since their anatomy is going to restrict other compensatory changes that we see in children and adults. Now let's talk about upper airway structural differences. We see adults on the left and children on the right. So relative, a child has a larger head, and this is a problem in the setting of a floppy head or malpositioning of the baby. This can really obstruct their airway. Babies are obligate nose breathers, and this is fine if their nose is patent, but let's say they have a cold and they have a lot of nasal mucus and it gets plugged up. Well, they're not able to breathe through their nose and then become mouth breathers, which is less efficient. They have smaller nares, and for the same reason, this is a problem. If they're obstructed or swollen or full of mucus, this can cause a lot of problems with breathing. Children also have a smaller mouth, and this allows for a smaller amount of air to pass through. It can easily be obstructed by the larger tongue that is present, and they also have a larger epiglottis in the back of their throat that can further complicate problems. The larynx and glottis are found higher in the neck, and the baby will have a more flexible trachea. So this is really important when you're positioning your patient and when they're sleeping at home. The airway is also narrow, and we'll talk about that. Now let's talk about the major differences in airway diameter. Respiratory disorders can cause significant proportional changes in the pediatric airway size, and this can further compromise the pediatric respiratory status. Here on the left, you'll see an infant's lumen. The diameter is patent about 4 millimeters, and on the bottom, you'll see an adult airway. The lumen is patent about 8 millimeters. Now let's say both of these patients get a cold. This is going to increase the wall thickness by about 1 millimeter circumferentially, and the patient will also develop mucus in the airway. This is going to cause a 50% reduction in the diameter of the pediatric lumen to about 2 millimeter size. And the adult patient, they're going to have the 1 millimeter of circumferential increased wall thickness, and this is still going to allow for 6 millimeter diameter in their airway size. The infant has additional resistance due to their narrow lumen. Now let's talk about the bronchial walls. The bronchial walls are supported by cartilage. Pediatric patients have less muscle tissue present, and so these are more prone to collapse. Also, the beta-adrenergic receptors are immature, making these patients less responsive to bronchodilation. Let's talk about the cilia. These are the small hair-like structures that help move mucus and expectorate this out of your body. At birth, these are poorly developed. These babies have ineffective mucociliary escalator, which means they're unable to fully propel the mucus out of their body. They can't really clear their secretions, and this puts kids at risk for airway obstruction from mucus. Let's talk about surfactant. Surfactant is a phospholipid produced by the type 2 pneumocytes in the lungs. It's going to reduce surface tension and keep the alveoli open. This is formed about 23 weeks of gestation and then again at 30 to 34 weeks. Premature infants have insufficient surfactant. Thus, they have increased surface tension, they have difficulty expanding their alveoli, and this can cause an increased work of breathing, and they can develop atelectasis or lung collapse. So if a baby is going to be given surfactant after birth, the first dose needs to be given as soon as a diagnosis of respiratory distress is made. And this is defined as the requirement of more than 30% oxygen and an abnormal chest X-ray. Now, prophylactic surfactant should be considered in intubated neonates born at less than 26 weeks gestation. Now let's talk about the alveoli. These are the tiny air sacs in the lungs that aid in gaseous exchange. Their function is to exchange oxygen and carbon dioxide to and from the bloodstream. There's very few functioning alveoli at birth, and these air sacs are going to increase in size and numbers as the baby matures. The majority of development happens within the first 2 years of life. Here you'll see normal alveoli. They're nice and expanded, ready to exchange gas. In the setting of a cold, a baby's going to develop a mucus plug, and this is going to start accumulating on the alveoli. The air is going to be absorbed from the alveoli, and slowly the lung segments can collapse. Because the alveoli are small and immature in children, they're more susceptible to collapse and atelectasis. Even when they're functioning properly, these smaller sacs provide a smaller area for gas exchange. Now we will cover the components of a pediatric respiratory assessment. There are a couple steps to the respiratory clinical exam. This includes history taking, inspection, palpation, percussion, and auscultation. We'll touch on all of these. First, the history. When you take a history from a patient, you need to really listen carefully, ask clarifying questions, and this information is going to usually come from the parents and caregivers. Sometimes, depending on the patient's age, you can also interview the child. And you want to do a thorough chart review. You will get a lot of your clinical answers by looking through the chart. Next, you ask about the history of present illness. This is, why is the patient there? You're going to ask about the origin. When did their concern start? How long has this been going on? And what's the progression of their concern? Is there anything that makes their symptoms worse? And is there anything that makes their symptoms better? And what have they tried to remedy this condition? Next, you'll ask about their past medical and surgical history. And this is sort of the what happened before. You may or may not know this pediatric patient, and this will sort of set the scene. Do they have any sort of respiratory history? And this includes patients with asthma. Have they ever had pneumonia? Do they have any allergic disorders like eczema, urticaria, which are hives, or hay fever? Because we know that allergic conditions are also associated with certain respiratory conditions. Has the patient ever been put in the hospital, and have they ever had surgery? Are there any previous radiology studies, such as a chest x-ray, that can be helpful in comparing with today's studies? What is your patient's immunization status? Are they up to date on vaccines? A lot of conditions that cause respiratory problems are vaccine preventable. Next, you want to delve into the family and social history. This includes secondhand smoke exposure. And is there any family history of asthma or similar conditions? Because these are familial. Next, we'll move on to the inspection category. This involves a primary observation of your patient's respiratory movements. You're going to assess for the respiratory rate. Now, for infants, you're going to count for 1 full minute because the respiratory rhythm or tempo can vary significantly. In older children and adults, you can do 30 seconds and multiply it by 2. You'll assess the respiratory rhythm. Is this regular? Is it irregular or periodic? You're going to look at the depth of respirations. Is your patient breathing deeply, or do they have shallow breathing? What is the quality? Are they working to breathe, or are they calm? If it's unlabored, that's normal. They're calm, they're breathing well. If it's labored, that means they have increased respiratory effort. Next, you'll want to assess the breath sounds without any listening device, and this is where you're just sitting next to your patient and listening for sounds coming when they breathe. The normal pediatric respiratory rates are going to vary greatly based on the age of the patient, and this is really important for the nurse and the clinician to know. So here we see, starting with premature babies all the way down to greater than 12-year-olds, there's extreme variation on the normal respiratory rate in breaths per minute. On the right-hand column, the heart rate's going to vary as well. The nurse really needs to know the ballpark of these norms to know if your patient is in sort of a red flag zone, too fast or too slow. So you're going to want to pay attention to these numbers. The next step is palpation. And this is where the clinician's going to assess the temperature and integrity of the skin. They're going to palpate for cervical and axillary lymph adenopathy. And this means palpate the lymph nodes in the neck and in the armpit. These are the chains that filter the chest wall and the lungs, and these can enlarge with certain conditions. You're going to palpate for bulges, abnormal movements, and tenderness. Next, you're going to check for symmetric respiratory excursion or chest expansion. And this is where the provider puts their hands along the patient's spine. And you have the patient take a big, deep breath. When they're maximally inhaled, the hands will spread apart evenly. When the patient breathes out, the hands should come back together symmetrically. If they don't come back symmetrically, the patient may have a respiratory condition like a collapsed lung, which is a pneumothorax, or a consolidation or pneumonia. Next, the clinician will do tactile fremitus. This is where the clinician will assess the density of the structures below the skin by feeling for vibrations as the patient says 99. An increase in tactile fremitus indicates denser or inflamed tissue, and that can be caused by certain diseases such as pneumonia. A decrease suggests air or fluid in the pleural space, which can be caused by conditions like asthma. Next, you're going to percuss your patient. This can help you determine if an air-filled or tissue-filled cavity is below the skin. Air-filled structures produce a resonant sound, like a drum, and fluid or tissue-filled cavities generate a dull sound. This can be used to detect conditions like pneumonia or other infiltrations in your patient. So this technique is more of an art than a science. This takes a lot of practice. Allow your hand to swing freely at the wrist, hammering your finger onto the target at the bottom of your downstroke. Your wrist has to stay relaxed because a stiff wrist is going to force you to push your finger into the target, and that's not going to get you the correct sound. This technique takes a while to discern the different sounds. Now, when you percuss over the patient's chest and back, if you percuss over a bone, you're going to get a flat sound. When you reach the lungs, you're going to get a more tympanic or resonant sound, like a drum. And when you're over the patient's visceral organs, you're also going to get a flat sound. Remember, this technique is all in the wrists. The technique involves using a pediatric stethoscope if indicated. If the tool is too big, you won't be able to isolate the breath sounds. You'll ask the patient to open their mouth, and you're going to listen directly on their skin. You don't want to be listening over a gown or clothing, because this can cause sounds similar to rhonchi. You want to make sure the patient is sitting up if they're able, and this is going to allow them to fully expand their lungs. In each position, you're going to listen for one complete respiratory cycle. That includes a full inhalation and a full expiration. Don't forget about the apices of the lungs, and these are found above the clavicles. You also want to listen all around the rib cage, under the axilla, so that you get every lung field. You're going to compare the sounds bilaterally, and you're going to be listening for any adventitious or abnormal breath sounds. You're also going to be checking during this exam, does your patient cough? When you listen to a child, you're going to be comparing the equality of the breath sounds, and you're always comparing the right with the left in the same level of the lung. You're going to be listening for diminished sounds, and this can show up in the setting of a pneumothorax or a consolidation. And you're going to be checking for air exchange bilaterally. The normal breath sounds, we have bronchial, bronchovesicular, and vesicular. The bronchial sounds are a tubular and hollow sound heard over the trachea and sometimes the mediastinum. The expiratory phase in bronchial sounds is slightly longer than the inspiratory phase. The next, as you move down the chest, is the bronchovesicular sounds. These sounds are heard over the main bronchus region. These are the normal sounds in the mid-chest area, and these are heard also on the back between the scapula. In this phase, the inspiration and expiration are of similar duration. Last, you'll listen for vesicular sounds, and these are found over the lesser bronchi, the bronchioles, and the actual lobes of the lung. The inspiratory phase is longer than the expiratory phase, and these are low frequency, non-musical, and they're barely audible at rest. Next, you're going to listen for wheezing, and similar to turbulent wind and airflow whistling through a chimney, the airway can also cause a whistle, and this is a high-pitched sound that's flow-dependent, and it can be present on inspiration, on expiration, or both. Next, you'll listen for crackles, and these are high-pitched, short-duration sounds. They can indicate that the patient is trying to move secretions. You're also going to listen for rowels, and these are discontinuous rattling, bubbling, or clicking sounds, heard usually during inspiration. Next, you'll check for rhonchi, and these are low-pitched wheezes. They're continuous, and they often sound like snoring. They can be present on inspiration and expiration, and sometimes these clear with a cough. Last, you're going to check for stridor, and this is a high-pitched wheezing sound caused by a disruption of airflow in the upper airway. There may be a foreign body obstruction, mucus, or edema that blocks the airflow through the upper airway, and this can usually be heard on the other side of the room without needing your stethoscope. Next, you're going to listen for a cough. Is it present or absent? You can also ask the parents about this if the patient isn't currently coughing in the clinic. Characteristics, you want to ask, is this a wet cough or is it a dry cough? Certain conditions are associated with each. Is it paroxysmal? Does the patient get coughing spasms? And we worry about this in the setting of pertussis. Is the cough worse at night? This is typically the condition, and it's usually from the postnasal drip. As the patient lays flat, the cough will worse at night. This is really frustrating for patients and for their parents. They're always asking, what can I do to help my child stop coughing at night? And we encourage symptomatic care as propping pillows, honey and warm water or tea, or taking sips of water. Is the cough barking, or does it sound croupy? These patients may have croup, which is a tightening of the upper airway.
I'm going to have you stand up and kind of walk around the table, and we're going to just start taking a look at Matteo, making sure that everything is where it should be.
Okay.
All right. Kind of scared to look at that diaper, Mateo.
Would you like me to lay him down or sit him?
Let's see what he'll do. If he wants to sit for right now, I think that's fine. So for the students, I am going to listen to his heart and lungs first because he's nice and quiet right now. That might be a little bit out of order from what you would expect from a head to toe physical exam, but if he's crying, I won't be able to hear anything. So, oh goodness, talk to me. So I'm gonna listen to his lungs in all the fields, and they sound great. Great. Oh, I know. Do you like that? And you might need to distract the baby while you're doing the exam. All right, so I'm listening to the lung fields in the back. Make sure you give yourself time to get a good listen. Yeah. Then I'm gonna come back around and I'm gonna listen to the heart sounds. You wanna listen in the left sternal border, the right sternal border, down, and the apex. And I don't hear any murmurs. His heart sounds great, so no concerns there. All right, Mateo. So I give a quick palpate to the head to make sure that I don't feel any deformities, any overriding sutures, anything like that. And then I come down and I palpate his sweet little cheeks and his neck. Oh, we dropped our toy. I'm gonna take a good feel, make sure I don't feel any lymph nodes. While I'm doing this, I'm looking to see if his ears look nice and symmetrical. I'm looking for any ear tags or any ear pits, which would tell me that there might be a congenital issue. Oh, you're gonna chew on my fingers, huh? Maybe got some baby teeth coming through pretty soon. I'm also gonna be looking at his eyes. I want to make sure they're properly set in his face, that they're not very low set or very wide apart or very close together. I'm looking at his little nose to make sure that I can see in both sides. And I'm looking at his mouth. So I am not opening his mouth or sticking my finger in just yet, because what I really want to do is get a look at his ears while he's nice and quiet. So, Mom, I'm going to have you, Neely, come back around here and I'll hand him to you. And I'm going to show you how to hold him so that I can get a good peek in his ears. Okay, so if you want to take a seat. All right, Mateo. And I want you to hold him facing you. All right, so Mom's got a nice good hold on him, and I'm going to get the ear speculum. We're gonna take a peek here. And now, Neely, what I would like for you to do is take this hand. Yes, and he's not gonna like it, but I want you to hold his head to you tightly.
Okay.
All right. And then sometimes I need to get up on the little stool to be able to really see. I'm going to use my finger to brace against his cheek. I'm going to pull his ear back and down. And then I'm going to take a quick peek. Oh, and they look great. And Mateo is not enjoying this exam. So can we turn his head the other way? This one's going to be a little bit easier to hold. Great. You're just gonna hold his head as tightly to you as you can. Now I'm gonna take this finger and I'm gonna brace it against Mateo's cheek because we don't want this otoscope going too far in. All right, and he let me look. So that is amazing. Often this is gonna cause kiddos to cry. Oh, there he goes. I hurt your feelings. I'm so sorry. I'm so sorry. And if the baby's crying while you're looking at the ears, it's gonna make the tympanic membranes look a little bit red. So if you can at all do it, you want to do that part of the exam while the baby's quiet. Since he's already mad, I am going to put my glove on, and we're just gonna look at your little mouth. He's not gonna like this either. Or maybe he will. All right. His palate is great. He has a great gag reflex, so everything's working from that standpoint. Oh, I got some real tears. Some real tears. Now I'm going to take my light and we're going to check for a red reflex. All right. Perfect. And I'm just going to try to get a peek up those little nostrils. Again, this is not a part of the exam the baby usually likes, and you don't have to, especially if you see some snot coming out. And now I'm bracing the forehead back against mom. Yep, looks nice and open. I don't see anything to be concerned about there. Okay, now let's put him on the exam table. I'll hold him for just a moment. Oh, and I want you to notice that he's appropriately looking for his mom. When I take him, he wants to know where mom went. Oh, all right. If we can just lay him on the exam table, we can give him something to play with. Hi. Hi. Do you want that toy? Yeah. Now we're going to take a quick peek at him, kind of head to toe. Oh, I know. I know. Sometimes a medical assistant will take all of the clothes off. I usually don't require that because sometimes the exam rooms are a little bit chilly. So just expose as much of the skin as you can. One of the things that I'm looking for are any rashes or birthmarks. Are there any birthmarks that you've noticed? No. Okay. So his skin feels nice and soft. I don't feel any rashes. I don't feel any sandpapery spots. All right, I'm just going to palpate the clavicles. They feel good. All right, and I know that I've seen him move his extremities and that his shoulders are nice and open. So the next thing that I'm going to do is I'm going to listen to his abdomen. All right. So I should hear some bowel tones, and I hear quite a few bowel tones, which explains the diaper that is probably dirty at this point. All right, so that sounds great. So next I'm going to examine Mateo's abdomen. At first I want to just kind of lightly lay my fingers and see how soft it is. If it's not soft, that would be a trigger that something might be wrong. And then I'm going to get a little bit deeper. So he's probably going to tense up a little bit, but that's okay. Once I get my fingers in there, he'll relax a little bit. Oh, and everything's feeling good. I don't feel any masses, anything concerning. So I'm going to check for his liver. The way I do that is I palpate up from the hip bone until there it is. I feel the liver, and that's right below the rib cage. And then check for spleen. And looking for umbilical hernias. There's nothing poking out here, so that looks fantastic. Nothing poking out here or here, where you might have an inguinal hernia. So everything on that tummy looks great. If you get a taut or a hard abdomen, or you notice anything pooching out around the umbilicus, that would be something you would need to investigate. Oh, what are you doing that? What are you doing? You're asking me what I'm doing. So after the abdominal exam, I would come do a quick GU exam, which we're going to skip for this recording. But what I would be looking for on a little boy at 4 months is the skin around his penis. I want to make sure it's nice and pink. It's not reddened. It's not broken down. I want to make sure that if the child is not circumcised, that you can pull that foreskin all the way back, that it's not too tight. And then you want to go around and make sure that his anus looks okay, that it's not reddened, that you don't see any signs of skin breakdown there. Then I'm going to make sure that our legs are moving and they're doing everything that I would expect a baby to do. And while I'm doing that, I'm looking to see if the skin folds on his legs match up. The other thing that I can do is I can put his feet on the exam table and I look to see if his knees are the same level. If all of that looks good, then that means we probably don't have a problem with our hips. And I think your hips are looking really good. So I've noticed already that there's 5 fingers on each hand. One of the things that I do is I offer him my finger, and at this point at 4 months, he still has a palmar grasp. So when you put something into his hand, he closes his hand around it. And when you do that with his little feet, when you draw your finger down the foot, then you see that those toes kind of curl in too, and that's appropriate for this age. All right, skin looks great. I'm just gonna roll you to this side so you can look at mama. I'm going to pull up here and I'm gonna assess his spine. It's nice and straight. I'm looking for any kind of dimple in this area. I don't wanna see a sacral dimple. Oh, we definitely have a dirty diaper. We'll get you out of that real quick, bud. No sacral dimple noted. That's another sign of congenital birth anomalies, but you look fantastic. All right. You're like, enough of this sitting down. Occasionally at this age, you might be able to elicit the walking reflex. Not yet for him. Sometimes when you put their feet on the table, they'll look like they're trying to walk. All right. But overall, Mateo, you look fantastic. All right, Nieli, he looks fantastic. I did not see anything on my exam that I'm worried about. He's meeting all his milestones. I think that we're safe to see you back at your next well baby exam, which will be at 6 months. Do you have any questions or concerns that we didn't talk about?
No.
Fantastic. All right. Well, we will have some materials for you to print out and take home because you get a lot of information during these exams and sometimes you forget. So we'll print those resources out for you and please just let us know if you need anything in the meantime.
Okay, thank you very much.
All right. Bye-bye, Mateo.
Here's an introduction to pediatric respiratory disorders. Why is this important? Well, respiratory disorders are the most common cause of hospitalizations in the pediatric population. The leading diagnoses for all hospitalizations in pediatric patients, excluding newborns, in the United States are pneumonia, asthma, and acute bronchitis. Here's an overview of the anatomy of the pediatric respiratory system. It all starts with the nasal cavity, plus the paranasal sinuses, and this is one way that air will enter your body. It'll go through your nostril. Another way is through the oral cavity, or your mouth. Then it will go down to your pharynx, your larynx, which is your voice box, and down through the trachea, which is your windpipe. This will extend to the 2 main bronchus stems and go further down into the lungs. Nurses always need to remember that children are not just smaller versions of adults. The respiratory system is under neural and hormonal control. The pediatric respiratory system varies anatomically and physiologically from the adult respiratory system. The clinician needs to understand these differences in order to manage the pediatric respiratory system. So when a child is born, most of the anatomic structures of respiration are present, but they're immature and underdeveloped. When a child takes their first breath, this is when the structures begin to expand and mature. So newborns and then young children move along the continuum and compensate only by increasing their respiratory rate because they don't have a large lung volume. The structures are also immature. You can see as children get older, they're able to further increase their lung volume to compensate for respiratory problems. Now let's talk about the respiratory disorder Croup. What is croup? Croup is a symptom characterized by infection and inflammation of the upper airway, which is the trachea and larynx. Here on the left, you'll see the normal larynx. There's a normal tracheal opening, and the vocal cords are not swollen. Over on the right, you'll see an inflamed larynx. In the setting of croup, the vocal cords and the surrounding structures cause a narrowing of the trachea, and this causes the symptoms we see in croup. Some children are more prone than others to develop croup symptoms when they get a viral upper respiratory infection, and most outgrow croup by the age of 5 when their airway becomes bigger. Croup is more prevalent in the autumn, winter, and spring, and typically lasts about 1 week. The most common cause of croup are viruses. The parainfluenza viruses types 1 and 3 are responsible for about 80% of cases. Influenza A and B can also cause croup, along with the respiratory syncytial virus, or RSV. The adenovirus and rhinovirus can also cause croup symptoms. Rarely, croup is caused by a bacterial infection, including Staph aureus, Strep pyogenes, Strep pneumoniae, Haemophilus influenza, and M. catarrhalis. First, the infection, which is usually viral, will infect the laryngeal mucosa. Then inflammation, hyperemia, edema, and epithelial necrosis and shedding begin due to the irritation from the virus, and this is going to start the narrowing of the subglottic region. The child will then begin to breathe more rapidly and deeper to compensate for the narrowed airway. The respiratory rate and effort increase in this stage as the patient tries to move the same amount of air through a much smaller space. Next, the patient will develop stridor, which is turbulent airflow. Imagine you're sitting in a cabin in the woods and suddenly a blizzard develops. Near the fireplace, you'll hear a whistling of the air as that turbulent airflow goes down. Well, that's the same thing that happens in the airway, and that's stridor. You can hear it on the other side of the room without a stethoscope. The patient's chest wall will start retracting to try to help the lungs move in more air. Next, the patient will develop asynchronous chest and abdominal movements, and the overuse of these muscles will cause the child to fatigue. This is a very important stage to recognize and intervene before the child fatigues too much. Lastly, hypoxia and hypercapnia will develop, and this can progress to respiratory failure and arrest. Now let's talk about the signs and symptoms of croup. It typically starts as a mild cold, but it can progress quickly. The cough associated with croup is very characteristic, and the parents will often say that their child has a croupy cough when they bring them in for care. It sounds like a barking or a seal-like cough, and you'll know it when you hear it. Signs and symptoms of the respiratory tract include difficulty breathing, fast breathing or tachypnea, noisy breathing, shortness of breath, wheezing, and stridor. As the respiratory status worsens and the work of breathing increases, the child may become anxious or agitated as they become air hungry. They may also have a lot of secretions to clear and also have a sore throat from all of the coughing and the irritation in their airway. Their nose may have clear nasal congestion, and the child may have a hoarse voice or laryngitis. Symptoms of croup are always worse at night and when children are crying or upset. The clinician will want to limit their agitation during the exam to minimize exacerbating these symptoms even further. Croup is a clinical diagnosis. There's not an actual lab test to diagnose this. It's based on the history. Has the patient had any recent colds, including a fever, runny nose, nasal congestion, a sore throat or cough, and the physical exam. The clinician's going to interpret the vital signs and will perform a full physical exam, including the head, eyes, ears, nose, throat, cardiac, respiratory, and skin systems. The child will also have usually a barking cough during the visit and have a hoarse voice and some inspiratory stridor. The child may have a low-grade fever. And typically with croup, there's an absence of wheezing. This is different than children with asthma or a reactive airway. How do you manage croup? Well, most cases are a mild viral illness that can be managed at home, but rarely croup can be severe or life-threatening. Unfortunately, we don't have any medications that will make the inciting virus go away any faster. So the focus on croup is on making the child more comfortable while the virus can run its course. Remember, antibiotics do not treat viral infections. The first step in managing croup is to administer corticosteroids. This could be dexamethasone or prednisone, and this is a mainstay treatment to help decrease the swelling in the upper airway. Unfortunately, these medications take a while to work. They can take 4 to 6 hours. So you want to give them early in an outpatient setting so they can get on board before the symptoms worsen that night. Another option in more extreme cases is racemic epinephrine. This is when the patient's airway is being acutely compromised and the patient does not have hours to wait on their steroids to work. This is administered via a nebulizer treatment. It will very quickly decrease the airway swelling and should be done in a hospital setting because any patient that requires racemic epinephrine is at risk for airway compromise due to the severity of their croup. Here's a child receiving racemic epinephrine nebulizer treatment, and you can see they also have a nasal cannula with some supplemental oxygen. Another management technique is to administer acetaminophen or ibuprofen. This can help decrease the sore throat associated from the coughing and can also make the child just generally feel better. Remember, ibuprofen can only be administered in greater than 6-month-olds. A controversial management technique is humidified air. It has debatable efficacy. It used to be the mainstay, but delivery devices have been evolving and humidifying crib tents are no longer used. In studies, they found that the particle size created by blow-by humidifiers is not optimal for deposition in the larynx. And also they've studied warm and dry or cool and dry air, and that actually produced the greatest reduction in airway resistance, whereas there was no reduction in the moist air group. Some countries have completely abandoned this treatment regimen, although in the United States, the standard for inpatient and outpatient management of croup still includes humidified air. In the primary care setting, you're going to want to create a steam-filled bathroom or bundle the child up and take them outside into the moist air. If it's cool outside, the parents can also roll the windows down in the car. Complications of croup are rare. They can include secondary bacterial infections after the viral infection has passed. This includes ear infections, sinus infections, and pneumonia. Dehydration can develop, and this can be because the child's breathing faster. They're going to lose more fluids through their insensible water loss with their breathing. In addition, they may feel really lousy and they just might be napping most of the day, missing out on opportunities to drink. And they may also have a sore throat. And all of these factors can put the child at risk for dehydration. Encourage the parents to push fluids and encourage water-rich foods such as Jell-O, applesauce, pudding, fruits, and popsicles. Respiratory distress can also develop with croup. Some children are going to develop complications that need additional respiratory support. It's important for the clinician to perform frequent and thorough respiratory exams to watch for signs of decline. The child may need additional support, including oxygen, IV fluids, and racemic epinephrine. Children with increased risk factors include those with a history of lung or neurologic disorders, such as asthma, and children who are more likely to develop severe croup symptoms may require hospitalization. Now let's talk about strep throat. It's also called streptococcal pharyngitis. This accounts for a small percentage of sore throats. It's a bacterial infection. This is transmitted by direct contact with mucus or sores of someone else with the strep bacteria. This can be via kissing, droplets, sharing water bottles and utensils, or from fomites, which are inanimate objects that are covered in the strep bacteria. This is caused by strep pyogenes, which is a group A beta hemolytic strep, or GABHS, and this is a gram-positive cocci that is present in chains. The strep bacteria is going to adhere to the specific receptors on the host cells, and the bacteria will adhere to the pharyngeal and dermal epithelial cells. Then it will start to invade the host tissues. The bacteria will start to release these pyogenic exotoxins, and that will cause your patient a fever. Signs and symptoms of strep throat usually include a sore throat that starts pretty rapidly. I'll see patients come in and they'll say, "I felt fine yesterday and now I can barely swallow." They'll have the pain when they swallow, and usually a fever is present unless they're on antipyretics or medications to decrease their fever. They will have red and swollen tonsils sometimes with white patches and streaks, and this is called exudative tonsils. They may have tiny red spots on the roof of their mouth, and these are palatal petechiae. The lymph nodes in the neck in the front may be swollen at the tonsillar level and the anterior cervical lymph node chain. And when patients come in, they want to know, do they have strep throat? And so you have to discern, could they maybe have a virus? Signs and symptoms of strep usually do not include a cough, and a cough is usually present when your patient has a cold. Strep doesn't usually have a runny nose, but patients with a cold usually will have a runny nose. Strep doesn't usually cause hoarseness or laryngitis. This is also usually present with viral illnesses like colds. And conjunctivitis is usually not present when a patient has strep throat. Now let's look in. On exam, your patient will open their mouth and you'll use your light to look at the back of the throat. You're looking for a few characteristics. The first is the soft palate. It's going to look red. The uvula may be red and enlarged. You're going to be looking at the tonsils, and remember, you're going to be grading those according to size. There may be these tiny red pinpoint hemorrhages on the soft palate, and the patient may have the white or yellow patches on their tonsils. These are all of the classic signs and symptoms of strep throat. Remember, you're looking for throat redness, pus or exudate on the tonsils, anterior cervical or tonsillar lymph node adenopathy, palatal petechiae, which are those small pinpoint hemorrhages. Your patient will have a fever, unless they're on antipyretics. Abdominal pain. Now this seems like an atypical symptom of strep throat, but let's talk about this a little bit. So strep throat makes the lymph nodes swell in the neck. We know this, but it also makes the lymph nodes in the abdomen swell, and these are the mesenteric lymph nodes. Often in kids under 5 who present with abdominal pain for no other cause, we will run a strep test because this can be due to the swollen lymph nodes in the abdomen. Your patient can have a fine raised rash on the trunk, and this is the scarlatina rash. Remember, your patient with strep throat typically does not have a cough. If your patient has a cough, they usually have a viral illness. Now, when a patient presents with a sore throat, the clinician needs to decide if the patient needs a strep test. We don't test every patient who presents to the clinic with a sore throat. The way to do this is with a diagnostic criteria called either the Centaur criteria or the McIsaac criteria. Here's an example. You score the points based on the patient's symptoms. They get a point if they have a fever. The patient will get another point if they have absence of cough. The patient will get another point if they have tender lymphadenopathy in either their tonsillar or anterior cervical chains. They will earn another point if they have tonsillar swelling or exudate, so the maximum for this is 4 points. That's the Centaur criteria. Next, you can adjust this based on the patient's age, and this is the McIsaac criteria. So we know that strep is most prevalent in the 3 to 14-year-old population, so kids will gain another point. If your patient is 15 to 44 years old, they won't add or subtract any points. And strep is less common in the older adult population, so if your patient is older than 45 years, you will actually subtract a point from their score. Next, the clinician will total the points. If the patient scores 0 to 1 points, it's unlikely to be strep pharyngitis causing their symptoms. It could be from a virus or a cold, and no further testing or antibiotic treatment is recommended. If the patient scores 2 to 3 points, it is recommended to do a rapid antigen test, and this is a rapid strep test. You can also do a follow-up throat culture. Now, in these patients, we would only treat if the rapid strep test is positive or the throat culture is positive. If your patient receives 4+ points, meaning they have every single sign of strep throat and or adjusted for age, they only have a 52% chance of having strep throat. The other 48% of the time it's going to be viral. So these patients, you can treat empirically while you wait on their results, but this is a discussion to have with your patients because that's not without risk. Here you can see a positive test result. This can be a dark positive line in addition to the control line or a faint positive line. With strep testing, any line is considered positive. Here you'll find a negative. This means there's only the control line present. This is an invalid test. This means the control line didn't show up as it should, and this patient should either be re-swabbed or retested. So how do you manage strep throat? Well, strep throat's typically going to go away in 3 to 7 days with or without antibiotic treatment. Although if strep throat is not treated with antibiotics, the patient can remain contagious for 2 to 3 weeks, and there's a higher risk for complications, such as rheumatic fever. Remember, your patient will be contagious with strep throat until they're on antibiotics for 24 hours, so they need to stay out of school, work, and community activities. Patients with strep throat should be treated with an antibiotic that is likely to eradicate the organism, and they're typically on 10 days of treatment. Penicillin or amoxicillin are commonly recommended because they're effective, they have few adverse effects, and they're affordable. It's important to remind the patient to complete the treatment and not save any extra antibiotics. Patients can also treat their symptoms with acetaminophen or ibuprofen, and this can help them manage their pain and their fever. And warm saltwater gargles are also a great option for controlling their throat pain. Now we'll cover varicella. Varicella, also called chickenpox, is a very contagious viral disease. It is caused by the varicella zoster virus. This typically affects 2 to 8-year-olds, but can affect anyone. It's usually mild but can be serious, and this causes itchy skin lesions that can scab and scar. This is a vaccine-preventable disease. The etiology, this is caused by the varicella zoster virus, or the VZV, and this is a double-stranded DNA virus that's part of the herpes virus family. It's the same virus responsible for shingles. After someone has had chickenpox, the virus can stay dormant or rest in the nervous system for the rest of their life, and it can reactivate or wake up later as shingles. This used to be very common in the United States prior to the vaccine. There used to be 4 million cases per year, greater than 10,000 hospitalizations, and over 100 deaths. We know based on records that chickenpox dates back to early civilizations. So it's transmitted in a highly communicable fashion. Infection rates in non-protected patients is greater than 90% in close contacts. The infectious particles are cell-free virus particles derived from 2 things: skin lesions and the respiratory tract. Now, the virus can be spread in 2 ways. The first is droplet transmission, and this is via coughing and sneezing, because remember, your patient is expelling these droplets even prior to the rash appearing. The second is direct contact with blisters, saliva, or mucus of a person infected with chickenpox, and then you'll touch their contaminated items, such as their clothing. If a person has never had chickenpox and they come in direct contact with the blisters of a patient with shingles, the virus can spread and lead to chickenpox in the patient who's never had chickenpox nor had the vaccine. Now, you may have heard of pox parties, and this is where parents invite the whole neighborhood over to see if they can get all the kids to have chickenpox when one child has chickenpox. Typically, they strip the kids down into their underwear and they want them to touch each other's rash to try to get chickenpox. But what these parents need to remember is the kids can also acquire this via the droplets, coughing, and sneezing. And these pox parties are not recommended. So chickenpox is contagious from 2 days prior to the rash appearing until all of the blisters have crusted over. And this is a problem because patients don't know they have chickenpox, the parents don't know their child has chickenpox, and they're still sending them to school and community activities. So after varicella zoster infection, IgG and IgM, and also IgA antibodies are going to start to appear. And this can be in the first 2 to 5 days after the rash. And this will show highest levels at about 2 to 3 weeks. The IgM antibody levels then rapidly decrease, and they typically can't be found after about a year after infection. Although the IgG antibody level is going to decrease slowly over time, the rate at which their protection wanes is different for everyone. Remember, the IgG is the long-term immunity, the IgM is with the acute exposure. Sometimes the IgG will wane, and a patient will be susceptible again to the virus and can actually get a second exposure, but sometimes it confers a lifelong immunity. You'll also develop cell-mediated immune responses that are going to limit the scope of the infection. So the pathology. Varicella is going to spread from the mucus and the skin lesions to the local sensory nerves. Here, it will stay latent in the dorsal ganglia cells of the sensory nerves. If the patient's re-exposed to this virus or in a stressful situation, this can reactivate and result in herpes zoster, which is shingles. Here you'll see the nerve fiber. The dormant varicella zoster virus is going to stay here, and at the right moment, when the immune system is weakened, it can awaken. It can travel up the nerve and cause a burning pain and a sensation to develop on the skin. I often have patients say, it feels like there's a tag on my shirt that's rubbing my skin, but there's not a tag there. They just get a sort of irritating feeling. Next, pus-filled blisters are going to appear on the skin, and these last about 3 to 5 days. Then these will form a scab and heal. And remember, these shingles lesions stay only on half of the body, right? They don't cross the midline, and they stay in one dermatomal tract. So this is very, very easy for the clinician to diagnose clinically. The patient, after having shingles, can develop a post-herpetic neuralgia, which is nerve damage caused by the virus, and this is going to cause an intermittent or continuous nerve pain in the area affected by their shingles. The patients have described pain as burning, stabbing, shooting, throbbing, or sometimes even like electrical shocks. Here we see the timeline of the signs and symptoms of varicella. On the left, you'll see your patient's going to be exposed to the virus. Then they're going to enter the incubation period, and this can be up to 21 days before they start showing symptoms. Next, your patient's going to develop classic cold-like symptoms. They may have a fever, fatigue, headache, malaise. Patients can get a runny nose and a cough. So to assist in your diagnosis, you always want to inquire whether or not the patient had cold-like symptoms preceding their rash. Next, the rash is going to appear. And this is an itchy, blister-like rash, and it's typically found on the trunk and limbs, but I've even seen patients with lesions in their mouth. They're going to progress through their infectious period until all of these lesions are scabbed, and then the patient will experience complete resolution. This rash is pretty classic. It's going to start as a papule. These are red bumps that are raised and appear over several days, and this is really key. They don't all appear at once. Then they turn into a vesicle. They're going to fill with fluid, and these look like blisters, and this happens in about 1 day, and then they're going to break and leak. Finally, they're going to crust and scab over. Characteristics of the chickenpox rash are that this child are going to have papules and vesicles in different stages of maturity, since these crop up over a few days. Now, I've had patients come in and they're early on in their chickenpox, and it looks like they kind of have bug bites. I ask the parents, have you noticed these appearing over a sequence of days, or did these all appear at once? Typically, if a patient has bug bites, they'll get them all at once. They were playing outside, but when patients have chickenpox, each day they're going to get new lesions. This can help in the diagnosis. The rash has also been described as resembling a dewdrop, which is the vesicle, on a rose petal, which is a little bit of erythema. The patient usually has these lesions again in all 3 phases and typically will have 200 to 400 lesions in a sequence of 2 to 4 crops. Here we see the classic phases. Again, you have red or pinkish bumps in the first phase. Then these are going to turn into vesicles and they're going to become fluid-filled. Finally, they're going to crust and scab over. Here's another sequence, and this varies based on the patient and it varies based on the severity of their chickenpox, but you can see day 1, not a big deal. Day 2, they might still be going to work and school. Maybe they think they had some, a mild cold followed by some bug bites. But then as the days progress, these lesions mature and change. Chickenpox is usually diagnosed based on a complete medical history and a physical exam. You're going to start with the vital signs of your patient. This is always a good place to start. They're usually normal when your patient comes in with chickenpox. Next, you move down to the head, eyes, ears, nose, and throat exam, and this needs to be thorough. Next, you'll do a cardiac exam and a respiratory exam. And finally, you check the skin. You'll want to look at the patient's skin, looking for all different lesions, and seeing if they're raised, seeing if they're tender, and looking for other signs of infection like secondary bacterial infections. So how do we diagnose chickenpox? Well, it's mainly a clinical diagnosis based on the history and the telltale rash. So if you're going to have a patient come in to be checked for chickenpox, you want to try to encourage the parents to call the clinic first to avoid exposing all of the other patients in the waiting room during the visit. So one of my children actually had chickenpox after he was vaccinated, and we'd gone camping. And throughout the week, we all had our itchy bug bites from camping and sleeping out in the woods, and he was getting new lesions every day. Well, he'd been going to school all week, and by the time it got to Friday, I realized that all of our bug bites had resolved and he was getting these new lesions. So I called the pediatrician and I said, sorry, I've sent my kid to school all week. I think he has the chickenpox. And they said, well, he's had his vaccines. That's not that common, but we'd like to see him. So they asked me to call. I parked in the parking lot and called the pediatrician's office when we got there. And the nurse came out and let us in through the back door, the rash door, and into a private isolation room. And turns out, clinically, the providers did diagnose him with chickenpox. There are other ways to diagnose. You can do a varicella zoster PCR, and I do this in the clinic if the patient has a lesion and is just a little bit ambiguous, you're not quite sure. And to do this, you'll use a viral swab and you'll find the really juicy lesions, and they need to be unroofed, so this can take a little bit of effort, can be a little bit painful. And you'll swab on the lesion, get the juice, and send it to the lab, and they'll be looking for the varicella zoster DNA. Another is a Sank smear. You can do a viral culture, but again, this takes time to get the results. Blood work can be done, including an IgM, and remember this is your antibody that shows up early with acute infection. And then IgG, and this is your patient's titer. This is the antibody made later, and this shows their subsequent immunity. In utero, this should be done at least 5 weeks after a mother has a primary maternal infection, and this can be done on ultrasound. Or a PCR test of the mother's amniotic fluid can be done, but remember, an amniocentesis is a high-risk procedure. These are the most common signs and symptoms of iron-deficiency anemia. The patient's going to look pale. They may be irritable or fussy, and they're going to lack energy and tire easily. Maybe this patient was previously active and now they're laying around. They just don't want to go run and play. Tachycardia, or a fast heartbeat. The heart rate's going to increase to try to distribute the oxygen around. There are less red blood cells, and each has less oxygen carrying capacity, so the body's going to compensate by increasing the heart rate to deliver the blood and oxygen to the tissues. A sore or swollen tongue. This is called glossitis. Low levels of iron are going to lead to low levels of myoglobin, which is a substance in the blood that plays a role in muscular health, including the tongue. An enlarged spleen, and something called pica. Now, this is when a patient wants to eat items without nutritional value, such as dirt or ice, and the reason for this is unclear. When a patient presents with these symptoms, they should be evaluated for iron-deficiency anemia as a possible cause. So in most cases, anemia is diagnosed with pretty simple blood tests. Routine anemia screening by checking a hemoglobin level is done because this condition is so common in children and they're often asymptomatic. The American Academy of Pediatrics recommends anemia screening with a hemoglobin blood test for all infants at 12 months of age, in addition to performing a risk assessment. The risk assessment questions try to identify patients with risk factors for iron-deficiency anemia, including children with feeding problems, poor growth, and children with special healthcare needs. If the hemoglobin level is low on the initial screening, then more follow-up tests are done. This includes a CBC, a complete blood count, and this is going to check the red and white blood cells, the blood clotting cells, which are the platelets, young red blood cells called reticulocytes, the hemoglobin, hematocrit, and there will be a differential if indicated. A peripheral smear. This is a small sample of blood that's going to be looked at under a microscope. Blood cells are checked to see if they have a normal size, shape, and color. Iron studies. Blood tests can be done to measure the amount of iron in your child's body. Here are the components to the CBC, or the complete blood count. You'll see a total red blood cell count, a white blood cell count including the differential, the platelet count, the reticulocyte distribution width, and that's going to measure the variation in the red blood cell size. This is called the RDW, and it's usually elevated in patients with iron-deficiency anemia because their body is constantly trying to churn out more cells. You'll see the hematocrit, and this is the ratio of the volume of blood cells to the total volume of blood. And finally, the hemoglobin. This is the protein responsible for transporting oxygen and iron. Next, you'll see the calculation of the red blood cell indices. First, this starts with the mean cell volume, and that's the cell size. You'll also have the ratio of the mean cell hemoglobin concentration, and then the mean cell hemoglobin. When we're looking at iron-deficiency anemia, we're really looking at the MCV, the size, and the MCH, which is the color. Part of this includes the peripheral smear and all these red blood cell indices. Cells can be a normal size, which is normocytic, too large, which is macrocytic, or too small, which is microcytic. And the cells can also have different levels of hemoglobin. So a normal cell is going to be normochromic, or they can have too little hemoglobin, which is hypochromic. There's no such thing as a red blood cell with too much hemoglobin. So here on the left, on the normal peripheral smear, you're going to see normal size. These are normocytic. You're also going to see a normal color, so these cells are normochromic. On the right, you see a patient smear with severe iron-deficiency anemia. Now, there's different characteristics when you look at these cells. Remember, they're going to be smaller than normal, so they're microcytic. And they're going to be pale cells because they don't have enough hemoglobin, so they're hypochromic. And there's also going to be a change in the variation of the size. So anocytosis means there's a huge variation in the size, bigger than normal. And poikilocytosis means they're variable in shape. Next, you're going to do an iron panel. And the iron level, the total iron level, is going to tell you the amount of iron carried by transferrin. Next, you'll see the ferritin level, and this is the amount of stored iron. The patient can have an artificially high ferritin in the setting of an infection, late-stage cancer, severe inflammation, and alcoholism. You'll also see the transferrin level. And remember, transferrin is the transfer protein, and this is going to be produced by the liver. When patients have liver dysfunction, they're going to make less transferrin. And last, we have the total iron binding capacity, and this is the measure of proteins available for binding iron. If a patient has low iron levels, they're going to have more proteins and docking sites available for binding. Now let's compare the blood. Here on the left, there's a normal patient. They're going to have a normal total iron binding capacity, or TIBC, and they're also going to have normal levels of their serum iron, serum ferritin, and transferrin. On the right, we see a patient with iron-deficiency anemia. They're going to have a high TIBC, or total iron binding capacity, because these sites are open and they're just ready to capture the iron. They're going to have a low serum iron, they're going to have low serum ferritin because they don't have any iron stored up, and a low transferrin saturation. So these are the diagnostics. Remember, we're going to do a CBC, and the characteristics of iron-deficiency anemia are a low MCV. So these are microcytic cells. They're small. They have a small volume. A low hemoglobin and a high RDW. Next, you'll do the blood smear, and you're going to see this microcytic hypochromic anemia, and in severe cases, you'll see the poikilocytosis. And you're going to look at biochemical indices, which is your iron panel, and these patients will have decreased serum iron, decreased transferrin saturation, decreased iron stored, which is their ferritin, and an increased total iron binding capacity, waiting to capture more iron. The signs and symptoms of sickle cell anemia are going to vary. Fortunately, sickle cell crisis does not occur in infants under 5 to 6 months of age. The child will still genetically have sickle cell disease, but does not show any of the signs and symptoms. After birth, the fetal hemoglobin is still in circulation, preventing a sickle cell crisis. However, once the fetal hemoglobin is replaced with adult hemoglobin, usually around 5 to 6 months of age, a sickle cell crisis is possible. The severity of symptoms can vary and can present as fussiness in babies. Your patient may have jaundice because remember, the sickled cells do not live as long as the normal red blood cells. A regular red blood cell lives about 120 days, but in sickle cell anemia, remember, they die after 10 to 20 days. When they die, this waste product called bilirubin is released from the destroyed red blood cells and is going to start accumulating, causing jaundice, or the yellowing of the skin or eyes. The patient can also have classic symptoms of anemia, including frequent dizziness or lightheadedness, fatigue or malaise, irritability, pale skin or pallor, and delayed growth and development, and this is thought to be due to the lack of oxygen to the organs. Signs and symptoms of a complication involving sickle cell is called hand-foot syndrome, and this is where sickled cells are going to block the small blood vessels in the hands and feet. This causes pain, swelling, and a fever. This can affect one or both hands, and feet can also be affected. This condition typically lasts 1 to 2 weeks, and it's seen most often in kids 6 months to 2 years old. The treatment for this involves hyperhydration, or increasing fluids, and pain medication. A vaso-occlusive crisis means there's a reduced blood supply to the organs and tissues, called ischemia, and this is going to cause severe and acute pain. The signs and symptoms of vaso-occlusive crisis depend on the organ affected. In the lungs, this is called acute chest syndrome. In the brain, it can cause a stroke. In the eyes, it can cause retinopathy. The bones can develop avascular necrosis. The kidneys can show a nephropathy, and the penis can show priapism. Acute chest syndrome is a vaso-occlusive crisis that occurs in the pulmonary vasculature. This is a medical emergency, and the patient can die without immediate treatment. The patient will likely present in some form of respiratory distress and may be using their accessory muscles of respiration, or they may have nasal flaring to try to bring more oxygen into the lungs. Due to the massive inflammatory process, there will likely be leukocytosis on the CBC, which is an increased white blood cell count. The diagnosis of acute chest syndrome is made when a patient has a new infiltrate on their chest X-ray and at least one of the following other symptoms: cough, wheezing, chest pain, tachypnea, which is an increased respiratory rate, or fever. There are other complications of acute chest syndrome, including atelectasis, and this can happen when the patient has a lot of pain in their ribs or if they have a vertebral infarction, which is decreased blood flow in the spine. This can cause a lot of pain with deep breathing, so the patient's going to take more shallow breaths. They're going to have a decreased respiratory drive and cough. A true thromboembolism can happen, and this is due to the activated endothelial lining. There's a reduced red blood cell flexibility, and this is going to increase the red cell adherence. This can cause a vaso-occlusion. A fat embolism can be triggered due to a bone marrow infarction. And infections are another trigger of acute chest syndrome. These are the common infections that can trigger acute chest syndrome: chlamydia pneumonia, mycoplasma pneumonia, Staph aureus, Strep pneumoniae, respiratory syncytial virus, the parvovirus, rhinovirus, which is the common cold, and influenza and parainfluenza viruses. Another component of sickle cell crisis is called acute splenic sequestration crisis, and this is a medical emergency that can lead to death unless prompt treatment is carried out. It is usually due to a rapid enlargement of the spleen as a result of trapping the circulating blood in the spleen. This causes a drastic reduction in the blood flow to the other organs of the body, and there will be a life-threatening anemia. This typically occurs in children under 2 years of age. The child will have a rapid enlargement of their spleen called splenomegaly as a result of the circulating blood going straight to the spleen. This causes hypovolemia as there's a drastic reduction of the blood flow to the other organs of the body because most of that blood volume becomes trapped in the spleen. This is harder to recognize in a patient than those who have external bleeding because no blood is leaving the body, but the patient is still going to get hypovolemic as that blood available to maintain their hemodynamic stability is decreased. You will see a drop in the hemoglobin level of greater than 2 grams per deciliter. The patient will also develop reticulocytosis, which is an increased reticulocyte count as the body tries to churn out more red blood cells. The platelet count will begin to drop. The patient may or may not have a fever, and the patient will experience pain. The patient's going to then develop a life-threatening anemia and circulatory collapse. Death can occur in less than 30 minutes if the situation is not urgently corrected with blood transfusions and a splenectomy. Aplastic crisis is characterized by an acute drop in the hemoglobin level and a markedly reduced number of reticulocytes in the blood. This occurs when a patient with sickle cell disease is infected with a certain common viral or bacterial pathogen. The most common causes of infection are the human parvovirus B19 or fifth disease, and this is characterized by fever, malaise, and red cheeks that have a slapped cheek look. It can also be caused by other infections such as Strep pneumoniae, Salmonella, other strep infections, and the Epstein-Barr virus. During an aplastic crisis, the bone marrow has impaired production of red blood cells, and this causes a rapid and life-threatening drop in hemoglobin. Hemolysis is going to continue, but the bone marrow is not able to churn out new cells fast enough to compensate. The marrow will recover in about 7 to 10 days, and then red blood cell production will continue. The management of aplastic crisis is with a blood transfusion. Patients can also develop a stroke, and this is the most common central nervous system manifestation. The patient may experience weakness on one side of the body, also known as hemiparesis, and seizures may occur. After the stroke, the patient may have cognitive and behavioral effects, and children may have a decreased school performance. Sickle cell anemia patients are susceptible to infections as a result of the inability of their spleen to function properly. There's also a defect in their complement system, which is used to eliminate harmful microorganisms, and it's an important component of immune function. This defect in the complement system causes an inability to deal with encapsulated microorganisms in the body, leading to infection. Patients with sickle cell anemia are at increased risk for pneumonia, bloodstream infections, meningitis, and bone infections. Patients with sickle cell disease also experience chronic recurrent pain. Chronic pain is associated with depression and other psychological disorders. Compared with the general population, patients with sickle cell disease have a higher prevalence of depression. Here you can see the patient with sickle cell disease is having daily pain. This is going to contribute to a lower mental health related to their quality of life score and lower physical health because it hurts. In turn, this patient's going to also have a greater medical resource use, and this is going to result in higher healthcare costs.
Let's move on to Tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic heart disease, and it frequently shows up on multiple choice tests. So I think it's important to go through the tetralogy and really understand what it is. It's important to memorize the 4 findings in the tetralogy, and I'm going to go through them now for you. So there are 4 major findings, and it can look pretty complicated, but if I go through it one step at a time, I think you'll understand it. Here we go. On the left side, you can see a normal heart, and on the right side of your slide, you can see Tetralogy of Fallot. I'm going to walk through the tetralogy, the 4 findings in tetralogy, and I'm going to make it so you're convinced that it's not as complicated as it sounds. Let's start with an overriding aorta. In these patients, there is that connection between the 2 ventricles called the VSD. The aorta rides over that VSD and allows the mixed blood to go into the aorta. That's why these infants are cyanotic. Some of that right side of blood is shunting to the left through that VSD and up into that overriding aorta. So 2 of the findings in tetralogy are overriding aorta and VSD. So when you hear tetralogy, it's not really true. Maybe you could call it a triology of Fallot because you couldn't really have an overriding aorta without a VSD. If you imagine, how could the aorta ride over both ventricles unless there was a hole between them? Additionally, these patients have some pulmonary stenosis. Basically, as that area shifts over and you're allowing for that overriding aorta, there's a squeezing of the pulmonary artery, allowing for stenosis. That narrowed pulmonary stenosis results in a right ventricular hypertrophy. So really, it's the biology of Fallot in that you're both having the VSD and the overriding aorta, and the pulmonary stenosis resulting in right ventricular hypertrophy. However, realistically, this is just one thing. You could call it the Fallot if you want. The abnormal rotation of the conotruncal septum at the top part of the heart it's abnormally rotated as opposed to the intraventricular septum, the bottom part of the heart, and this whole shifting results in all these findings. It's really just a shifting of the upper part against the lower part of the heart that results in the full tetralogy. That might make it a little bit more clear. It's important to understand that children who have a high degree of pulmonary stenosis are going to be sicker than children who have less pulmonary stenosis. The key thing about how blue a baby is at birth is how much pulmonary stenosis there is. In a baby with a lot of pulmonary stenosis, more of that blood is going to get shunted over to the left side. In a baby with less pulmonary stenosis, it's going to go right up into the lungs, and that's going to be the distinguishing feature between a baby who's what we call a pink tet, someone with less stenosis and less cyanosis, versus a blue tet, a baby who has a lot of pulmonary stenosis and a lot of blood shunting.
Additional points that are high yield are the boot-shaped appearance of the heart on chest X-ray and the role of squatting. That increases peripheral vascular resistance and thus decreases the magnitude of the right to left shunt.
In this presentation, we're going to talk about an emergency situation that happens in patients that have diabetes, and that is called diabetic ketoacidosis, more commonly referred to as DKA. So we're going to talk about what the definition of DKA is, some causes and risk factors, presentation, what it's going to look like when patients have DKA, and we're going to talk about diagnosis and assessment. So what is diabetic ketoacidosis? It is defined by the presence of all of the following in a patient with diabetes. So the patient has hyperglycemia. So normally we would hope that a diabetic patient is really going to keep control of their insulin management and they're going to keep that blood sugar in a good range. But sometimes it happens that that blood sugar gets out of control, it gets too high, and generally if it's greater than 200, it's going to start to cause some problems. You also have to have the presence of metabolic acidosis. So this is going to be explained a little bit more in detail later, but just remember that when you have metabolic acidosis, that means the pH of your blood is going to be too low. And for diabetic ketoacidosis, we're looking for that venous pH, and it's going to be less than 7.3. You can also look at the bicarbonate level of a patient, and if that's less than 15, that will also mean that your patient is acidotic. The last thing that we're looking for DKA is ketosis. Right there in the name, right? Diabetic ketoacidosis. I love it when they make it simple for us. You have acidosis and you have ketosis right there in the name. So the presence of ketones in the blood or the urine. If you are measuring ketones in the blood, you're measuring beta hydroxybutyrate. I know that's a mouthful, but you'll get used to seeing that term. And when you're measuring the presence of ketones in the urine, that's when you're dipping the urine and you're looking to see for those ketones. We're going to talk about some precipitating factors for DKA, or things that might cause a patient that has diabetes to go into DKA. There are a couple of categories of things that can cause DKA. So if a patient is put on a particular drug, as given a prescription for something like corticosteroids, maybe high doses of thiazides, some of the second-generation antipsychotics, those are examples of drugs that can precipitate or cause DKA. Many times children present with DKA because they've had an illness. Perhaps they've had a respiratory illness, or they've had a stomach bug, something that is making them not feel very well. And that could cause the symptoms to get worse and can cause children to go into DKA. Endocrine dysfunction can also precipitate DKAs. Sometimes it's a new diagnosis of diabetes, and so the diabetes is not being controlled at all, and it presents with DKA. Non-compliance with insulin for people who have an established diagnosis of diabetes. Sometimes teenagers don't want to take their insulin, and they will just let that blood sugar get higher and higher until they start having difficulty and present with DKA. Sometimes it's because the insulin therapy is inadequate. Maybe they needed adjustment in their doses. So again, when you think of teenagers who are going through puberty, we know those hormones are going all over the place. And insulin is a hormone. So we really have to make sure that we're staying on top of the dosing. And if they've had big changes and haven't had changes in their insulin dosing, then they may present with DKA, even though they're taking the dose they were prescribed. So it's not always the teenager's fault. Additionally, there are a few conditions that can cause decreased effectiveness of insulin that isn't necessarily associated with diabetes. So acromegaly, thyrotoxicosis, and Cushing's disease are a couple of examples of this.
Welcome to our Pediatric Nursing Quiz. Let's put your knowledge to the test. In today's challenge, we're covering 4 essential areas of pediatrics: respiratory assessment, growth and development, blood disorders, and pediatric cardiology. There are 3 questions per topic, 1 easy, 1 medium, and 1 hard, worth 1, 2, or 3 stars. After each question, we'll give you a moment to think, and then we'll reveal the correct answer along with a quick explanation. Ready? Let's dive in. During the inspection phase of a pediatric respiratory assessment, which observation would indicate increased respiratory effort?
You'll assess the respiratory rhythm. Is this regular? Is it irregular or periodic? You're going to look at the depth of respirations. Is your patient breathing deeply, or do they have shallow breathing? What is the quality? Are they working to breathe, or are they calm? If it's unlabored, that's normal. They're calm, they're breathing well. If it's labored, that means they have increased respiratory effort.
An increase in tactile fremitus during palpation suggests which condition?
Next, the clinician will do tactile fremitus. This is where the clinician will assess the density of the structures below the skin by feeling for vibrations as the patient says 99. An increase in tactile fremitus indicates denser or inflamed tissue, and that can be caused by certain diseases such as pneumonia. A decrease suggests air or fluid in the pleural space, which can be caused by conditions like asthma.
During auscultation, the nurse hears harsh, high-pitched sounds that are primarily heard on inspiration and suggest upper airway obstruction. What are these sounds called?
Last, you're going to check for stridor. And this is a high-pitched wheezing sound caused by a disruption of airflow in the upper airway. There may be a foreign body obstruction, mucus, or edema that blocks the airflow through the upper airway.
At what age should a healthy infant approximately double their birth weight?
By 4 to 6 months of age, they should have doubled their birth weight. So that's a good rule of thumb to remember.
A 2-year-old recognizes a restaurant sign and becomes excited, expecting a meal. This behavior reflects which developmental stage?
And that's the pre-operational stage. It begins about age 2, it ends about age 7. This is a stage, it's marked by symbolic thought. So that is the goal of this stage. Symbolic thought means the ability to understand that a word or object can stand for something else. So for example, when I took my kids, when I drove them down the street and they saw the McDonald's sign, they knew they might be getting a Happy Meal, and they get really excited because the McDonald's sign stood for Happy Meal to them when they were toddlers.
A preschooler tells the nurse that the sky is sad because it's raining. What cognitive concept does this demonstrate?
Animism is another fun way of thinking that preschoolers are known for. So this means it's when they refer to, when they really believe that inanimate objects such as plants, foods, even the weather have lifelike qualities. For example, a preschooler may believe that the sky is sad when it's crying, or that a flower is happy because it's blooming.
The nurse is assessing a child suspected of having iron-deficiency anemia. Which of the following findings are consistent with this condition?
These are the most common signs and symptoms of iron-deficiency anemia. The patient's going to look pale. They may be irritable or fussy, and they're going to lack energy and tire easily. Maybe this patient was previously active and now they're laying around. They just don't want to go run and play. Tachycardia, or a fast heartbeat. The heart rate's going to increase to try to distribute the oxygen around. There are less red blood cells, and each has less oxygen carrying capacity, so the body's going to compensate by increasing the heart rate to deliver the blood and oxygen to the tissues. A sore or swollen tongue. This is called glossitis. Low levels of iron are going to lead to low levels of myoglobin, which is a substance in the blood that plays a role in muscular health, including the tongue. An enlarged spleen, and something called pica. Now, this is when a patient wants to eat items without nutritional value, such as dirt or ice, and the reason for this is unclear. When a patient presents with these symptoms, they should be evaluated for iron-deficiency anemia as a possible cause.
A nurse monitors a patient receiving multiple blood transfusions for aplastic anemia. Which complication should the nurse watch for?
While there's generally no limit to the amount of transfusions that can be given, there is a risk to receiving multiple transfusions. Transfused red blood cells contain iron that can accumulate in your body and can damage your vital organs with iron overload. Medications called chelating agents can help your body get rid of this excess iron.
How long do sickled red blood cells typically survive in circulation?
A normal, healthy red blood cell lives about 120 days, but a sickled cell survives for only 10 to 20 days. The body is not able to reproduce new red blood cells fast enough to keep up with this rapid destruction of the sickled cells. This results in a chronic hemolysis and anemia.
Which of the following is one of the 4 key findings in Tetralogy of Fallot?
Let's start with an overriding aorta. In these patients, there is that connection between the 2 ventricles called the VSD. The aorta rides over that VSD and allows the mixed blood to go into the aorta. That's why these infants are cyanotic. Some of that right side of blood is shunting to the left through that VSD and up into that overriding aorta.
Which of the following genetic disorders is associated with pediatric cardiomyopathy?
Examples are metabolic storage diseases such as Pompei's disease, conduction defects, mitochondrial disorders, ion channel disorders, muscular dystrophies. All of these genetic problems can cause a cardiomyopathy, and they'll be different depending on the cause.
A child's ECG shows a QTC interval greater than 450 milliseconds. Which condition is most likely?
In patients with a prolonged QT at baseline, they may have a syndrome that's causing that. There are 2 relatively well-known prolonged QT syndromes that are genetic. One is called Romano-Ward, and that's the most common one. And another one is less common, which is called Jervell-Lang-Nielsen. That one's interesting because it also comes with deafness in the family.
That's it for today's quiz. Count your stars and let us know how you did in the comments. Keep mastering those core PEDS concepts, and we'll see you next time.